Thank you so much, moderators, Your Excellencies, distinguished guests, all protocols observed. Good morning, everyone, and welcome to Rwanda. I want to thank you all for coming. Seems like it's early in the morning, though times have moved on. So I'm really happy to be with you. I guess we are the first speakers, so we are really ready to be doing that. And as was mentioned, today we are to tackle the issues of high consequence infectious diseases and how they are being managed. And it's really important to know that life on our planet is consistently being threatened by the emergence and the emergence of high consequence infectious diseases. And even as we speak, we are living it. Since none of us cannot forget the recent human loss and economic burdens that we are facing because of COVID-19 pandemic for almost the last 3 years. And with the climate change, we expected that high consequence infectious diseases are going to be coming up, and we expect them to be more of a norm rather than exceptions. And in Africa, high consequence infectious diseases are imposing on our countries huge economic losses, and more importantly, they are taking away the lives of so many of our brothers and sisters. And this is mainly caused by our continent or our country's limited containment capacity, limited personal protection capacity, efficient communication, and most of the time, lack of specific treatments. The coverage of and the convergence of people, animal, and environment has indeed created a new dynamic in which health of each group is inextricably interconnected with the health of the others. And this is causing the zoonotic diseases to be very frequent. Recent statistics are indicating that over 1,461 diseases that are now recognized in humans, approximately 6 of those are due to multi-host pathogens that are characterized in the movements across species lines. Over the last decades, approximately 75% of new emerging human infectious diseases were found to be originating from animals. And this is highlighting the contribution of various animal species in the spread of infectious diseases. The government of Rwanda has embraced One Health approach since 2011. And we have taken this as an approach to manage problems threatening humans, animal, and our environment. And since then, we have established a One Health Steering Committee, and presently we have it known as One Health Multi-Sectoral Coordination Committee. The One Health Multi-sectoral coordination committee is made of experts from ministries of health, Ministry of Agriculture and Animal Resources, Ministry of Environment, Ministry of Education, and the Rwanda Development Board. This organ was set to lead and advise on all matters related to One Health in the country, and it works in a partnership with other international organizations, including but not limited to CDC Africa, OIE, WHO, and FAO for the implementation of One Health activities. Through this mechanism, the policy documents governing the National One Health approach, namely the National One Health Policy and the One Health Strategic Plan, have been developed and we are currently implementing them. During the COVID-19 outbreak in Rwanda, the One Health team was broadened to add the local government under the national and local command posts. The same arrangement has been recently used to manage the Rift Valley fever outbreak that we experienced between April and August of this year, for which the implementation of One Health approach significantly enhanced the response coordination and timely carved down the spread of Rift Valley fever in both animals and humans. The preparedness and response plans for other 3 diseases of public health interest, namely the rabies, Rift Valley fever, and avian influenza, were also developed. The surveillance of infectious diseases is also being improved through the extension of the integrated disease surveillance response. Previously, that were restricted to humans, they are being extended to animals and wildlife, as well as to ensure the holistic surveillance of infectious diseases in both animals and humans. These efforts have been made and in the management also of antimicrobial resistance. Indeed, the baseline assessment of existing antimicrobial resistant testing capacity in both human and animals in Rwanda have been conducted. This assessment is helping to frame appropriate interventions aimed at enhancing the national antimicrobial resistance testing capacity. The emergence and re-emergence of high consequence infectious diseases cannot be managed by one sector. To secure human, animal, and environmental health, to secure the very future of this planet, we need more collaboration and partnerships. We need to stand together and work together if we are to strive together. And as the Minister of Agriculture and Animal Resources of Rwanda, we commit to actively continue to support the implementation of One Health policy by strengthening sustainable livestock farming and saving lives, as once you protect one, you protect all. Thank you.
Thank you very much, Honorable Mrs. Minister. Mrs. Dr. Geraldine Mukeshi-Mana, for giving us an overview of One Health implementation in the Republic of Rwanda. Now, we will listen to a pre-recorded video. The presentation of Professor Salim Abdul Karim, Director of CAPRISA. Professor Salim is a South African clinical infectious disease epidemiologist, and he will present the epidemiology of emerging and re-emerging infectious diseases in Africa. So,
good day. It's a great pleasure to be with you here today at the Cephia conference. I'm sorry, I'm not there with you physically, but I'm with you in spirit. And today I'm going to be talking about COVID-19. I'm going to be talking about its epidemiology. I'm going to be talking about its future. So, whether the epidemiology and the future of this infectious disease. I'll touch on just briefly by way of historical background, the virus and the disease, talk about the benefits of vaccines before the current state of the pandemic and the way forward. Now, historically, we think about this pandemic in terms of the large numbers of deaths, over 6.5 million reported deaths and over 20 million excess deaths. And if we look at where we are at a global level in terms of the number of new infections, at a global level, the level of new infections is also at an ebb. But that's partly a reflection of testing, partly a reflection of the new variants. But when we think back to those days in 2020 that we watched this pandemic grow and in an exponential way, and the huge burden that it placed on our healthcare systems, largely driven by the rapidity of spread, the fact that there was no immunity and that large numbers of people acquired the severe forms of this disease. And so it put pressure on our healthcare systems, large numbers of patients required ventilators, and we dealt with an emergency. Well, that emergency is now receding. We are now dealing with this pandemic in a slightly different way. And I'm going to touch on that when I talk about the way forward. Now, when we think about this pandemic, we think about COVID-19 and the traditional picture of the past of patients requiring oxygenation, patients having pneumonias, that is a perspective of this disease from 2020. The perspective of this disease now in 2022 is very different. We know that COVID-19 is not just an acute respiratory disease. It is quite literally a disease from head to toe. And I've used this diagram from nature to just illustrate that point, that in fact COVID-19 affects so many different organ systems. And we know that it's not just an acute illness, that in 20–30% of patients that they go on to getting long-term sequelae, what is now widely referred to as long COVID. Now, long COVID, patients in my clinic talk about, they feel they can't concentrate, they have fatigue, they have malaise, and it's widely described as this brain fog that doesn't allow you to function optimally. And so we're dealing now not just with the acute respiratory distress, we're dealing with a disease that has a long-term set of health impacts. So let's look at how our strongest weapon against this disease, how is that impacting the course of this pandemic? And when we look at that, there are 5 benefits of vaccines that I'll touch on. The first 3 are related to infection. So the one thing we know is from the original trials, and I'll come back to that in a minute in the next slide, is that the vaccines reduce the number of asymptomatic infections. They also reduced the number of symptomatic infections, and they reduced the number of severe infections. They seem now, with early evidence, to also be impacting on the incidence of long COVID, but they really come into their own in the fifth benefit, where they reduce the secondary attack rate to close contacts. So let's look at one of the very early trials. This is the initial Pfizer trial, one of the first to report on its results on COVID-19 vaccines. And in this trial, it was shown that mildly symptomatic infections were reduced by 95%. So a clinically apparent infection, marked impact of the initial Pfizer vaccine scheduled 2 doses on the strain that was prevalent at that time, the D614G strain. But one of the things that's not often recognized about this trial is that it also showed that the number of asymptomatic infections was reduced by 66%. So this trial set the pace for what we understand the impact of vaccines to be: a reduction in asymptomatic infection, reduction in mildly symptomatic infection, and even though those efficacies have changed with different variants. You'll see here how originally it was 95% effective against D614G, but that dropped with Beta down to 75%, rose to 88% with Delta, and with Omicron, we saw how if you'd been vaccinated a while ago, 4 to 6 months ago, the vaccines had very little impact on Omicron. And so we needed a booster. With a booster, the efficacy of the vaccine shoots back up to 75%. So we understand this impact, but what we have really come to appreciate is that regardless of which vaccine you take, regardless of when you took it, regardless of what the variant is, the vaccines remain really good in terms of efficacy against severe disease, hospitalization, and death. And in this regard, I'm just presenting to you data from the US, from New York State, not for any other. There are mountains of data that already illustrate this point, but just to give you some idea of what that data show. And this is a study of around 8.8 million people. And in the study, the 3 vaccines that are used in New York State, the Pfizer vaccine, the Moderna vaccine, and the J&J vaccine, all of them show pretty good efficacy, almost a year later even, in terms of reducing severe illness. And of course, this data that comes from the US CDC shows the impact of vaccines on deaths. A reduction of, in terms of deaths, in the region of around 15-fold. So there's early emerging evidence, and this data come from Israel, that suggests that vaccines not only reduce infection, but they also have an impact in the long-term sequelae, in reducing things like muscle weakness, fatigue, and tiredness. But it's really in this respect, the fifth benefit, the benefit in terms of transmission, that we see vaccines coming into their own. So this was a brilliant study published in the journal Science. It looked at families where both parents were vaccinated in one set of families and both parents were not vaccinated in another set of families. And they looked at infections that occurred in these parents, in vaccinated breakthrough infections and in unvaccinated when they got infected. They looked at what is the proportion of children who got infected, because the children are not vaccinated and the children have prolonged contact. And what they showed, vaccinated parents reduced the risk of transmission to their children by 72%. So we are very clearly seeing the benefits of the vaccines in terms of reducing the secondary attack rate. And in this study, published in the New England Journal of Medicine, it showed even further, where they looked at 146,000 odd contacts of individuals who were infected. Some of them had been vaccinated and others not. And what they showed is that those who'd received 2 doses of the Pfizer vaccine, they had a 68% lower chance of spreading the virus to others. And they looked at 4 different groups. They looked at this reduction applied to individuals who lived in the same home as them, individuals who just visited them, individuals they went to an event with, like going to the pub. And importantly, this reduction applied even to contacts in a workplace or educational facility. So that gives you some idea of the importance of vaccination, not just for the individual who benefits in terms of lower numbers of infections, but reducing the secondary attack rate. And that's an important benefit of vaccines that we have to acknowledge. But one of the things we're seeing now is that with large numbers of the world being vaccinated, and even larger numbers of the individuals in the world having had natural infection from Omicron because it spread so fast and so widely, that we've got individuals who've got vaccine immunity only, natural immunity only, and hybrid immunity, where they've got both natural infection and vaccines. In combination, those 3 forms of immunity are serving to reduce the number of clinical illness that we are seeing. So that as a result of reductions in the secondary attack rate, in terms of reductions in the hospitalization, the overall impact of new variations on Omicron have been quite minor. And so what we are seeing at this stage is the effects of immunity, particularly effects of hybrid immunity, natural immunity, and vaccine immunity in terms of dampening the overall impact and avoiding waves of new infections. So let's go on to the current state of the pandemic. Where are we now? Well, when we look at the situation, we are still seeing small waves and spikes across the world. We've seen spikes like that in France recently. China is still dealing with infections. So across the world, we are continuing to see these small spikes. What we are not seeing is these massive waves of infection as they go through country by country, literally sweeping through the world. And we're not seeing that in this stage because the nature of the way in which the virus is spreading and the minor mutations that are being caused, we are not seeing those waves anymore. We may see a wave, when there's a new variant like Pi, but at this stage, it seems that we're moving more along the lines of seeing spikes of infections rather than waves. And what we know is that for each new variant that we see, that each new variant is able to spread much faster. Indeed, this is a key characteristic. If a new variant can't spread faster, it can't displace the old variant. And in this diagram analysis, you can see alpha was almost 2 times faster than the original variant. Delta was 2.5 times faster. Omicron 6 times faster. BA2 9 times faster. You can see how being faster has been a critical part of how these viruses have come to dominate. And that's part of the challenge that we have been seeing. But even as these viruses have become, these new variants in Omicron have become increasingly more infectious and have the ability to escape immunity, they are still not causing large numbers of severe infections. So disease severity has been an important part of the diminishing effect of severity that we have been seeing the benefits of largely through immunity. But we have to expect that as the virus will continue to mutate, we will see a greater ability to escape immunity. And here I'm showing you the data from BA5. BA5 with 1 mutation all the way up to 8 mutations. And if you look at those mutations on BA5, you get some idea that 2 or more of these mutations lead to quite substantial escape from existing immunity. But that immunity focuses on antibody immunity. The virus has not been able to escape our T-cell immunity to the same extent. So that has meant, as we are going to be dealing with escape from immunity, that means that we have to be better prepared in terms of the tools that we use. And we've been going through the 3 eras of our response. The first era in 2020 was public health measures. We had lockdowns, we focused on washing hands, wearing masks, social distancing. But as we moved into 2021, we shifted our focus. We shifted our focus to vaccines. We now had a pharmaceutical intervention, a biological intervention that was highly effective. And so era 2 was the era of vaccination. And as part of vaccination, that's when we began to see new variants emerge, variants that could escape that vaccine immunity. And as we looked at this year, we have now been refocusing our response. And that now has been to focus on treatment. That taken early, a drug like Paxlovid has a marked impact, a 90% reduction in the number of patients who need to go to hospital. Unfortunately, Africa has not been at the receiving end of this important new ability to treat COVID-19. To me, that's unconscionable. Just as we had vaccine inequity, we are now dealing on this continent with treatment inequity. And I would hope that we would see early in the new year these drugs now become available in Africa as well, as they are now standard of care in much of Europe and the developed world. So let me end off with touching briefly on the way forward and touching on what we can see. The first is an important reality check, and that is that because this virus naturally infects a whole range of animal hosts, we can expect that this virus is going to be with us for a very long time, perhaps even forever. But that forever will not necessarily mean that we have to be dealing with a pandemic emergency as a result of this virus in the long term. And part of that is that as we look at each new variant of concern, we are beginning to see how we are moving towards a situation where at some point in the near future, I don't know when, but we can expect to see a variant emerge for which there are no further mutations that give it an enormous advantage. So the virus can't keep mutating to advantage, forever. There has to come a point where it will reach a stage where a variant that's now prevalent is one that's hard to replace. And when that occurs, we expect to see a shift. We expect to see no further waves because there's no new variants or variants of concern. They are minor mutations, but not completely new variants that have an advantage. And so we will see this virus moving from an epidemic state to an endemic state. It's not clear when that's going to occur. I hope, as I'm sure you do, that it'll be sooner rather than later. Because when we get to that endemic state, we'd need to make better vaccines that focus on that endemic form of the virus so that its impact becomes minimal and we will just broadly live with this virus at that time. But until then, we can continue and thrive in the midst of this pandemic. Now that this pandemic emergency is receding, we have to learn to live smartly with this virus. Not just learn to live with this virus, because we don't want to be just tolerate, we've got to learn to live smartly with it. And there are 5 things that you can do in living smartly with this virus. First, make sure you're fully vaccinated. whatever the recommended regimen is in your setting, make sure you've taken the full panoply of vaccines that are recommended. The second is be aware of the levels of community transmission. Are the cases rising? Are they just a low number of cases? Because then you can adjust your risk appetite accordingly. For example, when cases are low in South Africa, I don't hesitate to go to a wedding or to a function because the chances that there's an infected person in the room is very small. However, as cases are rising, that situation changes. I will not go to a function where there are thousands of people or hundreds of people. That now becomes a potential super spreading event. Know the potential risky situations you are entering and know what you can do to mitigate that risk. And key in that is to avoid poorly ventilated indoor areas. And if you have to go indoors and you have to deal with an indoor setting, wear a mask, and preferably wear a medical mask, because that's what will give you the protection you need. We do know that, like everything else, there is no protection that is 100%. But every little thing we do, every indoor risky setting you avoid, every time you enter an indoor setting which is risky and wearing a mask, you are reducing your risk of infection. And if you reduce your risk of infection, the number of transmissions in the community drop, the chances of mutations drop, and the overall impact grows. Because ultimately, it's not only about what you're doing for yourself, but you need to do what you can to protect others. And I'll end off on a key lesson that we learned from HIV for COVID-19. And that's the importance of mutual interdependence and shared responsibility. And I'd like to read from an UNAIDS document entitled "How AIDS Changed Everything." And I quote, "The AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity, we can change the course of history." And we've done so through global solidarity and the Global Fund, PEPFAR, and UNITAID. We have been able to mobilize large amounts of resources to ensure that even an individual in the most remote village in Africa will have access to antiretroviral treatment. We take that as our shared responsibility, that all of us have to do what we can to protect every person with HIV from dying, from getting ill, and from spreading the disease to others. And so we have to take that perspective in COVID-19. We've got to take that lesson into COVID-19, that no one is safe until everyone is safe. Thank you.
Thank you very much, Professor Salim Abdul Karim, for this brilliant presentation. There's no question after each presentation because Trevor will lead the panel discussion after all presentations. So now it's my pleasure to introduce Dr. Michael Irwezindu, who is the Director of Research at the United States Army. He is infectious disease physician and expert of global health. So, Dr. Irwezindu, the floor is yours with the presentation, Diagnosis and Management of Emerging and Re-emerging Infectious Disease in Africa. Thank you.
Thank you very much. I would like to first of all appreciate the organizers of this program for inviting me to give this talk. My name is Michael Irwezindu, and I work for the Henry Jackson Foundation, Medical Research International in Nigeria. We are going to have an aspect of this plenary that addresses epidemiology. So I'm going to be speaking on the subtitle, Diagnosis and Management of Emerging and Re-emerging Infectious Diseases. As you can all attest to, emerging and re-emerging infectious diseases remain a perennial hurdle for the whole world, and there is a disproportionate distribution in the WHO African region. In 2020, while we were all battling with COVID, we probably have forgotten that there were other emerging and re-emerging infectious diseases that were reported to the Africa CDC. So the question is, did they receive enough attention? Your guess is as good as mine. But in the interest of time, we are going to focus on Mpox, COVID-19, Lassa fever, and Ebola. Now, Mpox, which we before now knew as monkeypox, it's a disease of immense public health importance, which was traditionally endemic in Central and West Africa until this year when everything changed. And we know that there are two clades which have recently been renamed, clade 1 and clade 2. And the presentation of Mpox could range from mild to severe. But suffice it to say that the 2022 global outbreak has really, in many ways, questioned our conventional understanding of the epidemiology, the transmission, and to some extent, the clinical presentation of Mpox. Now, talking about the clinical presentation of Mpox, like I did say, it could range from mild to severe illness. Usually, there are two phases, an investigation phase, which tends to last the first 5 days, during which they present with mostly constitutional symptoms as listed on the slide. Then, which is followed by a stage of eruption where the skin lesions appear. But the dilemma is this. When somebody is at the stage of invasion, it will take a lot of magic to make a suspicion of Mpox, because it will just present like most other acute febrile illness we encounter in sub-Saharan Africa. But I want to highlight the importance of lymphadenopathy, peripheral lymphadenopathy, in the presentation of Mpox, because during the resurgence in 2017-2018, while knowledge about Mpox was still building up, it was something we deeply relied on, at least to be able to distinguish it from chickenpox and measles. I also talked about the rash. Usually between 1 to 3 days after the stage of invasion, now comes the rash. The rash tends to start from the face, then spreads centrifugally to other parts of the body. Compared to chickenpox and measles, the trunk tends to be relatively spared. However, Mpox has taught us that diseases don't read textbooks, because we've had patients who presented with disseminated lesions. And also, very importantly, in people who have severe disease, they could have complications. I would like to highlight secondary bacterial infection, which could lead to sepsis and multi-organ dysfunction. And like quite a number of emerging and re-emerging infectious diseases, monkeypox comes with a lot of psychosocial disturbances. We've heard about people who had depression. In my personal experience, 20% of my patients were depressed, and it's not very difficult to understand why. And we've also had cases of reported suicide in Mpox patients. I mean, those are some of the images we obtained from some of our patients in Nigeria. If any continent should be bothered about the emerging knowledge that HIV and Mpox might have an interaction, that continent should be sub-Saharan Africa for obvious reasons. We are now beginning to see that people with especially uncontrolled HIV are at higher risk of more severe disease, as you can see from some of those images. And they are also probably more likely to die. And they're also more likely to have more anogenital lesions. And we are also asking, is it possible that there might be mpox immune reconstitution inflammatory syndrome? And if indeed there is an interaction and mpox could impact the transmission of HIV, is there a chance that down the line we might lose some of the gains we have already made in HIV care, which will be quite disturbing? And of course, whether it's possible to have drug interaction between anti-mpox medications and antiretroviral drugs is something that should also worry us. So all these call for more research. In terms of laboratory diagnosis, it's recommended that we collect at least 2 swab samples from 2 different sites. And also, the stay of diagnosis has been nucleic acid amplification tests, specifically PCR. And if there are facilities for genomic sequencing, that will really also add more to the findings. It's not recommended to depend on serology, IgM and IgG antibody for confirmatory diagnosis. But that said, sometimes, for different reasons, you might return inconclusive test results after collection of skin lesions, samples from skin lesions. In such settings, having a positive serology test might be a helpful finding. The management of mpox is largely supportive. But I would like to highlight the importance of treatment for superimposed infections, especially bacterial infections, especially when there is sepsis, and also psychosocial support. And psychosocial support doesn't have to be pharmacological. We had some patients that we really had to invite mental health specialists for us to make a breakthrough in their management. And now, we know that there are antiviral agents like tecovirimat, like cidofovir, and including Yersinia immunoglobulin that could be administered intravenously. But the question is, for a continent that has had mpox for over 5 decades, why are these agents not readily available? Which is something we should be concerned about. And with the identification of monkeypox in high-risk groups, and also the unfolding interaction with HIV, we should also emphasize the treatment of comorbidities like HIV, sexually transmitted infections, and even non-communicable diseases that might coexist. Epidemic preparedness is something that Africa should make more investment in. Fortunately, before the onset of the 2020 global outbreak, my organization got a grant from the US Defense Threat Reduction Agency in collaboration with public health authorities in Nigeria, the Nigeria Center for Disease Control, the Nigerian Ministry of Defense, and the National Veterinary Research Institute. And between March and October, we have been able to conduct monkeypox capacity building, both sample collection, case management, and even other aspects of public health response. We've been able to train over 200 human and veterinary healthcare workers in Nigeria and Guinea. And we've been able to demonstrate how capacity building can actually improve both the knowledge and public health response skills of healthcare workers. So this is something I think Africa should invest in. And the good thing is, this capacity building is not mpox-centric. It cuts across other emerging and re-emerging infectious diseases. Now, COVID-19. The last speaker opened up our eyes to COVID-19. At the beginning of the pandemic, it was predicted that Africa was going to fare worse for reasons such as our fragile healthcare system. But we know about the story of COVID in Africa. It turned out to be a story of relatively low incidence as well as relatively low mortality. And there have been a lot of postulations as regards why it was so. In the interest of time, I wouldn't want to spend a lot of time on that. In Nigeria, Lagos State was the most affected in COVID. And this large cohort study demonstrates the fact that, yeah, we had the same symptoms as we are experiencing in other parts of the world. but 60% of our patients were asymptomatic, and only about 7% had severe or critical illness. And the previous speaker also talked about long COVID. Africa has also had its fair share of long COVID, but that is something I think we probably have not invested much research efforts and also treatment towards, because in a relatively smaller cohort in Lagos, we were able to show that over 40% of people had persistent symptoms. These are COVID survivors. So this is also a call for further investment in management of long COVID. Well, I mean, we are all witness to the fact that COVID, extrapulmonary manifestations of COVID are very important and probably contributed to more mortality than the pulmonary manifestations. I also won't spend so much time on this, but we have different testing platforms. We mostly use PCR and GeneXpert across Africa. And COVID has really demonstrated the critical importance of genomic testing. Now, Lassa fever. Lassa fever, the best way to describe Lassa fever is that it's even neglected among neglected tropical diseases. And the question is why? So in terms of presentation, uninterrupted Lassa fever could spread through 4 stages. And gladly, the WHO has come up with some of these algorithms that makes it easier for us to have clinical suspicion, given that the facilities for testing are really limited. And also, same for Ebola. I mean, compared to Lassa fever, Ebola is associated with more bleeding and also higher mortality. And we know there are 5 variants. The lessons we learned from the 2014-2016 Ebola outbreak really taught us that this disease has a lot of manifestations and could go through several stages. And untreated, the chances of survival is quite slim. And even with treatment, because most people don't present early, there is a lot of complications if they survive. And gladly, we also have an algorithm that makes it easy for people to be able to suspect COVID. But one thing I would like to point out is sometimes when people present, within the first 72 hours, they might return a negative test. And if you have a strong suspicion, it's advised to repeat tests, because we've had people who returned a positive test after initially testing negative. So from the Africa perspective, there are some challenges we need to highlight that make diagnosis a dilemma sometimes. One of them is the fact that presentation is usually non-specific, especially earlier on. And people, over-the-counter use of antimicrobials, antipyretics is very common in sub-Saharan Africa. So if you are expecting to see somebody with a temperature of 40 degrees Celsius to make your diagnosis, you may not find that. Bleeding may not be visible. And bleeding under the skin, like expecting to see petechia in a dark-skinned individual, is a challenge. And we also seen people whose bleeding coincided with their menstrual cycle. And in children, irritability and other forms of disturbances could be misinterpreted, and the diagnosis of viral hemorrhagic fever is missed. This treatment of viral hemorrhagic fever is largely supportive. We know that ribavirin has been used for Lassa fever and Crimean Congo hemorrhagic fever. Now, there are challenges we need to highlight, include infodemics. I would have to move closer to the screen. Management of infodemics, stigmatization. Stigmatization is a very big problem in emerging and re-emerging infectious diseases. Sometimes people are treated, but it's difficult for them to get reintegrated into the society. We still have people who have mistrust for treatment facilities, and rather they put a lot of trust in herbal medications. Some of the complications, like deafness in Lassa fever, are attributed to witchcraft. And this is real. How do we get around this? How do you hold a woman who has had viral hemorrhagic fever responsible for spotting while she's pregnant? It's beautiful to hear stories, good stories, success stories from treatment facilities like the IRWA treatment facility, like the Kanema General Hospital. But the stories we don't tell are the things that happen in primary healthcare facilities, the things that happen before they get to these centers. For how long can we depend on donor agencies? And sometimes samples are collected, they don't get to the destinations. So we must leave this conference, but we must answer the questions. Why don't we have a vaccine for Lassa fever after 53 years? What lessons have we learned from vaccine nationalism? If there is no cross-reaction between the Zaire Ebola vaccine, how do we handle the outbreak from the Sudan vaccine? So, in a nutshell, Africa must own and lead research efforts for diseases that affect mostly Africa. Thank you very much.
Thank you very much for this great presentation, Dr. Zindu. Now we will listen to Dr. Moeti, Regional Director of AFRO, WHO AFRO in Brazzaville, and it's a pre-recorded video.
Your Excellency, Paul Kagame, President of the Republic of Rwanda, Professors Agnes Binagwaho and Senait Fiseha, co-chairs of the Second International Conference on Public Health in Africa's Scientific Program Committee, Excellencies, colleagues, friends, brothers and sisters. I thank the organizers of the conference, especially the African Union, for providing this platform to connect and share perspectives and research findings in public health and strengthen scientific collaboration and innovation across the continent. COVID-19 has shown that global health crises impact all segments and sectors of society. It has underscored the importance of investing in public health and stronger health systems to prepare for and respond to emergencies while maintaining essential health services. Strong country-level awareness and preparedness of core teams yield good results. As we read in COVID-19, Make It the Last Pandemic, national responses were the most effective where decision-making authority was clear, there was capacity to coordinate efforts across actors, including community leaders and levels of government, and formal advisory structures were able to provide timely scientific advice that was heeded. In response to COVID-19, several initiatives have been put in place by WHO, countries, and partners, including a new global architecture for health emergency preparedness, prevention, response, and resilience, proposals for a pandemic treaty and targeted international health regulation amendments, and the establishment of the Pandemic Fund. These initiatives are designed to address the gaps in health security and essential public health functions. As a region, let's celebrate the progress in health. Estimates show that the median of years lived in good health in the African region increased from about 53 years in 2010 to 59 years in 2022. We must, of course, now factor in the effect of the pandemic. Estimates also show that coverage of essential health services in the African region improved from 39% in 2010 to 51% in 2022. 35 of the 47 countries now have medium essential service coverage. In the year 2000, there were only 3 countries with medium coverage, and 15 countries have or are on track to achieve high coverage. Despite this progress, most of our countries remain off pace to achieve universal health coverage by 2030. We are barely halfway through achieving full essential health service coverage with only 7 years left to 2030. Our region continues to lag far behind other regions of the world. Increased investment in building effective systems using a primary healthcare approach is pivotal to equitable and sustainable access to essential health services without financial difficulties and safeguarding communities from future threats. the primary healthcare level is the first contact of the healthcare system for over 80% of our population and provides direct contact to communities. Among others, addressing the shortage and brain drain of the health workforce, sharpened now post-pandemic by aggressive recruiting by some wealthy countries and clearly redefining the role of communities in public health emergencies, are vital. The 5.3 million health workforce gap in Africa is more than half of the global shortage. The African emergency workforce, including frontline responders who are mainly women, needs to be further prepared to ensure a timely response. With the Africa Centers for Disease Control and Prevention, we're supporting countries to achieve this ambition, which is already advanced in 16 countries. Partnership with the private sector remains crucial. I'm happy that in the African Union political agenda, African leaders prioritized local manufacturing, transfer of technology, and upscaling youth-led innovations. And I congratulate you, President Kagame, for taking the lead in local manufacturing. These efforts have yielded the first African-owned COVID-19 vaccine produced by Afrigen Biologics in South Africa. Proposals are also underway for establishing the African Centers of Excellence for Genomic Sciences. African scientists are generating new knowledge, and national investment in their efforts, together with international support, is critical. Our actions now in the future require accurate and real-time data to detect, inform, and promptly respond to public health threats. New technologies for data acquisition, analysis, and reporting are needed, building on what already exists. To end, I urge that the post-pandemic discussions, decisions, and actions be based on lessons from COVID-19 and other pandemics. As WHO will continue to work with member states and partners to build back better. I wish the Second International Conference of Public Health in Africa every success and will be waiting eagerly with my team to implement the main recommendations that will emerge. Thank you.
Thank you very much, Dr. Moeti. We will continue with WHO Afro, and we will have the last presentation by Dr. Fiona Braka. She's the team lead, emergency operations.
Good morning to everyone. It's my pleasure to build on the remarks from our regional director with an emphasis on the One Health approach, looking more at the area of research and some of the initiatives in the region to address this. A lot has been said about the burden of public health emergencies. At WHO, we are tracking the events across the region, and we have at the moment over 150 events that are being monitored. About 80% of these are due to disease outbreaks, and less than 20% are due to humanitarian crisis. We do publish this every week on the WHO website, and it is showing actually a very active region when it comes to public health crisis. We looked at disease outbreaks over the past 2 decades, and one observation is that zoonotic diseases account for 32% of the outbreaks that have been reported over the last 2 decades. We've also observed that there is an increase in the proportion of zoonotic diseases within infectious diseases over time. As you can see on the top right, The blue are the zoonotic diseases compared to the non-zoonotic, an increasing trend over time. And in terms of proportion, in the red trend, you can see that has also increased. Actually, when we compare the last decade to the previous decade, we have seen a 66% increase in zoonotic disease outbreaks. The most frequent ones are yellow fever that account for 22%. We have dengue, and we also have Lassa fever as the main zoonotic diseases. In terms of geography, almost all the countries have reported zoonotic outbreaks. West Africa especially, accounting for 41% of the zoonotic disease outbreaks. And in terms of countries, on the top list are DRC, Uganda, Mauritania, Senegal, and Kenya. These statistics underscore more than ever that it is time to have a collaborative One Health approach to respond to increasing threats to human life. What is driving these risks on the continent and globally? There are several drivers of risk that relate to infectious disease outbreaks. We are seeing increasing urbanization, and in instances where it's not planned, we have challenges with overcrowding, with water and sanitation conditions. All these increase the risk to diseases. We are seeing deforestation, encroachment of forests. That again also exposes people to animals, and we will see, or we have had, the risks associated with those interactions if they are not done in a safe manner. We are seeing migration also growing, challenges around crowds, around the conditions in which people migrate. We see pollution, increasing agriculture, animal production. In some instances, this is positive, but on the other side, we see that if the risks are not well controlled, these are actually posing risks to increase in the number of infectious diseases. So the interaction, human, animal, and the ecosystem is coming into play. Which brings us to the One Health approach. And I was pleased to hear the Honorable Minister of Agriculture for Rwanda expressing passionately about this specific approach and the efforts that are being made here in our host country. It is an approach that brings together all relevant sectors and disciplines across human, animal, and the ecosystem, the environment, to address health in a way that is more effective, efficient, and sustainable when all sectors are involved. It's the interplay between sectors and disciplines and society coming together to collaborate, to communicate, to coordinate and build capacities so that we have better well-being and that we can tackle threats to health and the ecosystems holistically. So that is the One Health approach. And when we look at some of the diseases that the previous speakers have talked about, just in terms of the, to demonstrate the human-animal interface, looking at monkeypox, we can see that over time, where this disease started was first detected in 1970 in Africa. Monkeypox, as has been said, is transmitted from wild animals through direct contact with man from bites or scratches or contact with fluids from the animals. And we have seen as early as 1970, most of the cases were sporadic. And over time, through urbanization, through deforestation, we have seen it moving more from zoonotic transmission to human transmission, which is really what we have seen with the recent large global outbreak of Mpox. And this is now a public health emergency of international concern, as you all know. But it's really to demonstrate that over the years, where we've had increasing human and animal interaction, we have also seen the marked increase in terms of cases and also global spread. There's a lot that we don't know yet, the unknowns, and research needs have been identified in the area of monkeypox. We still need to learn more about modes of transmission, about animal diagnostic capacity, about animal sources and routes of transmission, viral circulation in animal populations, and the social and economic behavioral risk factors for spillover of this disease from animals to the human population. There is strategic preparedness and readiness and response plan that is guiding the actions towards controlling monkeypox. One of the key components of this plan relates to countermeasures and research, trying to minimize zoonotic transmission of monkeypox. And it is hoped that further research will help us to better understand the modes of transmission so that we can develop risk reduction strategies at the human-animal environment interface. The other disease is COVID, and my previous speakers have touched on this. The SARS-CoV-2, which is the causative agent here, it has been confirmed in animals. And this shows the range of animals that are known to contract SARS-CoV-2 to date, with 3 categories. On the top row, you have those that are in direct contact with humans, for instance, pets or farm animals. These animals have been known to contract SARS-CoV-2. Second, in the middle are the animals that are in proximity to humans or in direct contact, like zoo animals or wildlife. And at the bottom row are those that only exist in the lab, like the genetically modified mouse strains or inbred animals in the lab. And from the left to the right is the increasing susceptibility of these animals to SARS-CoV-2. So it's a large range of animals, and these have been confirmed to be susceptible to the virus. We need to understand more about this. And so with that in mind, and the fact that there is a risk of animal reservoirs in African wildlife, we need to study this area more, because apart from potential risk of zoonotic infections, novel animal hosts can drive viral evolution, potentially leading to new variants, and these could be more dangerous in terms of our efforts to try and eradicate some of these diseases. So more research is needed. It can also help us to have better control measures. Some animals could get vaccinated, and in the end, we could limit the further risks of much bigger outbreaks that become uncontrollable. So again, to emphasize the importance of One Health and the importance of research in this area. So what are we doing about this as from a global perspective, but also a regional perspective? We have learned a lot from the COVID-19 pandemic, and there have been several recommendations that have been put forward from a number of assessments. And based on these assessments, WHO has defined 10 proposals to strengthen the global architecture for emergency preparedness, response, and resilience. And from a regional perspective, the member states, the African member states, have endorsed a regional strategy for health security and emergencies spanning up to 2030. And this was endorsed at the Regional Committee of Ministers of Health meeting in Lome in this past August 2022. So it defines a set of critical actions building on the lessons from COVID-19 as well as what we have learned from other outbreaks. The strategy for, or rather the regional strategy for health security is hinged around three flagship initiatives that they address preparedness, detection, and response based on extensive consultations with member states, with partners, to try and coin a comprehensive Africa-driven approach to the challenges that we are addressing. And I'll just mention one around the preparedness, which is aiming towards resilience of systems for emergency response. And it has a critical pillar around governance that is centered around multi-sectoral coordination in alignment with the One Health approach. Through this range of interventions, we envision a safer Africa region where outbreaks and other health emergencies have limited morbidity, mortality, and socio-economic disruptions. This is going to require a strong partnership. And we are really pleased to note the collaboration and partnerships around One Health, coming together to work with member states to address the issues that relate to public health. This is not exhaustive in any way, but it is really to an impetus to an advocacy that as partners, we really need to rally together and push the One Health approach forward as a sustainable, holistic approach to addressing the increasing public health threats on the continent. As I conclude, the world is evolving, and we are seeing increasing human-animal environmental interface. As this happens, we observe marked increase in zoonotic disease outbreaks over the past decade. The One Health approach is critical. It mobilizes multiple sectors, disciplines, communities to work together to foster well-being and to tackle threats to health and the ecosystem. We are learning more and more every day, but we still don't know a lot. And so we need more research, and this is where this conference is important. We have a range of scientists in the room. We want to tickle your curiosity, tickle your interest, to address some of these important questions that we have that could help to limit zoonotic transmission and negative effects on human, animal, and the ecosystem. Member states and partners need to work together to promote resilience of health systems for emergencies through multi-sectoral coordination in alignment with the One Health approach. You can learn more about One Health on our free Open WHO online course website. Feel free to log in and understand more around this important area of work. Let's work to make Africa a safer place. Thank you.
We'll just have a short moderated discussion to try and get us back on time for the conference. While Dr. Irozindu's coming to the stage, Dr. Braca, I want to thank you for the excellent talk you just gave. It was wonderful to have this session bookended by commentary on the One Health approach. It is such an all-encompassing and important, but very broad and diffuse topic. So we heard Rwanda's strategy and investment in this area, but how would you advise other governments to prioritize stepping into this space?
Thank you very much. Indeed, we are very excited to hear the initiatives in Rwanda around the One Health approach. We know that several countries are working on this as well. And we do encourage that those that have not yet set up the multi-sectoral coordination mechanisms to please do that. We can learn a lot from countries that are advanced, and there are tools that can help to initiate these processes in the countries. There is a comprehensive joint action plan that stipulates the key activities that are being promoted. We have guidelines. So it is important that we have all countries with this approach being implemented. As I mentioned, some of the initiatives that we will be working jointly with Africa CDC and other partners include the governance for public health emergencies, and that involves setting up the multi-sectoral coordination mechanisms where they are not in place, but also where they are in place, how we can strengthen them to effectively coordinate. It's not always easy to bring many sectors to work together, but it is much more effective because, as we have shown, unless we tackle all the different aspects that increase the risk for disease or disease outbreaks, we will continue to be in this cycle of transmission and risk in the region. So mine is an appeal and also a commitment that as partners we are here to support the governments to strengthen this area of work.
Thank you so much. And then Dr. Irozindu, I was struck during your presentation, sepsis came up multiple times as a complication of Mpox, of COVID-19, Lassa, Ebola. So as care providers to individual patients, what should we be looking for to optimize the care of people who may be coming in with any of these underlying emerging and re-emerging pathogens? And as public health professionals, what should we be watching for so that we detect emerging and re-emerging pathogens that may be masked by people coming in just very, very sick with sepsis?
Thank you very much, Dr. Kaur. Yeah, so regarding sepsis diagnosis, I think one of the greatest problems we face is that most of our treatment or isolation centers are not purpose-built. So they don't have the diagnostic capacity. So you still collect samples and maybe just do confirmatory testing. Because we can't take samples from individuals with highly contagious infections to the general lab, where they don't have a containment platform, it's better to have a containment lab, general lab, that is inbuilt in the isolation or treatment facility, so that beyond making the confirmatory diagnosis, we should also be able to diagnose other co-infections or comorbidities, so, which is something I would strongly advocate, so that we don't take samples out, because the more you take samples out, the more you put other individuals at risk. So from the time of presentation, even when you think the suspicion is not very high, get a baseline, right? And have a very high index of suspicion. And when you are not sure, please err. Yeah, because most times by the time they become septic, they have multi-organ dysfunction. Some of the drugs used in treatment cannot even be tolerated. Yeah, so that would be my suggestion. Then please, can you take the second question again?
And the second part is just from a public health perspective. You know, it may be difficult, for example, to test every single patient who comes in with a febrile illness for any of the possible causes that might be emerging or re-emerging. So from a public health approach, could you comment on maybe pooled specimen testing or wastewater testing or other strategies?
Yeah, so I would start by strengthening our surveillance system. For instance, we all know that between the months of October, November, and April, the incidence of Lassa fever, for example, becomes very high. But the question is, to what extent have we used those surveillance information? So if we have surveillance information, we have algorithm. Because we know we have limited resources, at certain times of the year, we should be able to divert more resources towards some testing, because around that time, the incidence of some of these emerging and re-emerging infectious diseases are higher. Then, also when we are receiving funding, just like COVID has taught us, when we are receiving funding for epidemic response, let's make it sustainable. So what we are saying is the PCR platforms we have used for COVID testing should not lie dormant in our facilities. We should be able to leverage them. That will reduce the costs. We should be able to leverage them so that we can widen the spectrum of pathogens that we are testing. Thank you.
All right. I want to thank both of the panelists so much for joining me on stage right now. Thank you so much to all of the speakers who contributed to what was really an excellent session today. A colleague this morning referred to this event as the World Cup of Public Health in Africa, and I feel like this session was just such a wonderful, This was a wonderful way to get it started. Thank you all for attending, and enjoy the rest of the conference.
Thank you so much for all the panelists and the opening session. We're now going to take a very short 10-minute health break. We invite you to stretch your legs, grab water. The official opening ceremony with our guest of honor